You got a fan over there? What in the world? You set a camp.
I aspire to be the Carter's level of extra.
Oh, you actually brought it?
Is that hooked up to your USB port?
No, it's wireless.
I think muscular sclerosis is incorrect, multiple sclerosis, I don't know why that's even up there, so we'll have to look at it. But, how many of y'all dealt with an MS patient? Has anyone seen an MS patient? How severe were they?
He can't do anything.
So is he at the nursing home?
Yeah, like he's just lost control of his hands basically,
So he's,
and his arms.
so he's got it really bad, do you know how long he's had it?
I think he's had it 2-3 years now.
That's
Maybe
not very
longer.
long.
It might be like 4.
How old of a man is he?
I think he just turned 60.
Okay, so that's a really severe case of MS. I worked with a girl years ago before I ever became a PT, and she died in 6 months. So it can be very, very severe, or people can live with it for all of their lives and live a normal lifespan. So MS is one of those things that we just don't know too much about. It used to be called the crippler of young adults because it would occur in people in their 20s. And then a lot of times they go into remission and then it would come back. And so it's, I don't know that they call it that anymore because they know a lot more about it. When I first got out of PT school, which was in 1983, they did not know what caused multiple sclerosis. I don't know why I have muscular there, I have to get rid of that. They really didn't know what caused it. And so then they started, when the MRI came out, then they could diagnose it. So all of the MS cases before the MRI came out were just based on symptomatic stuff. So that it was very difficult to diagnose. People didn't know whether they had it or not, so it was really a horrible thing. And it still is a horrible thing. I hate multiple sclerosis and I hate Parkinson's disease. It's very difficult because you go back in and see those patients over and over again. Sometimes the same ones, and you get them as best as you can, and then they deteriorate, so you go back in again. And so it's a very difficult disease for people because it is downhill for them, right? And so they have to really fight it and fight it hard. Frequency for multiple sclerosis is 2 to 1, female to male. And so most of the MS that I've seen has actually been in females. For years and years, the colder climates have more MS. Isn't that interesting? And so you had a really low frequency, and I don't know exactly when this came out, but it's been, I don't have any recent stuff. I did check this all about 2 years ago, and it was pretty up to date. 5 in 100,000 in Asia and Africa, which are very warm climates. And then a medium frequency in southern, even in the United States. It's much more common up in the northeastern part and the northern part of the United States versus the southern United States. So we don't see as much of it down here as they do up in the northern part. It's just kind of what it is. They've always known that about it. Etiology, it is viral, they believe. They've pretty much figured out that it is viral. Although you will have people who, in families, where you'll have a mother and a daughter who both got it, or you have an aunt and someone who got it. So multiple sclerosis, basically you see sclerotic patches through an MRI and a CT scan and different things throughout the brain and spinal cord, and it shines up as just a shiny spot, and there's an example of that right here, where they just see a shiny white area that shows up. And so that helps diagnose it. And it really does help them to have a diagnosis. You know how awful it is not to have a diagnosis. It doesn't matter what you're dealing with. When you know what it is and you can fight it, But when you don't know what it is, it's very difficult. And so you see people who deal with chronic fatigue and they don't know what it is, and it's just scary to them. So it's helped a lot with MS patients that they can now diagnose it through an MRI. Charcot's triad is a term that you need to know. It's been around for a long time. Basically, it's three things that happen with multiple sclerosis. It's an intention tremor. And so what an intention tremor is it's a tremor with movement. What is the other tremor that we know about? A resting tremor. And what disease did we see that with? Y'all know?
Parkinson.
Parkinson's. So it's that pill rolling where they're at rest. They have this tremor in their hand. But when they're moving, they don't have a tremor. Well, with MS, what you see is they're fine at rest, but when they move, they'll have a tremor. So when they're reaching for something or moving their arms, you'll see the tremor then.
So it's just what it causes. It's just called Charcot's.
Charcot's triad. These are three things that go with MS. So you have the intention tremor, the scanning speech, and then the nystagmus. And is this with all MS patients? No. You just need to know this term because this has always been part of MS. So you do see nystagmus with it. And where does the nystagmus come from? In which part of the brain normally with MS? Cerebellum. Remember, most nystagmus comes from the cerebellum. Diagnostic criteria is multiple signs of neurological dysfunction and then MRI findings. There are also lab tests. You can have a cerebral spinal fluid evaluation with immunoglobulin abnormalities, so they do a lot of blood work on them and check also for the cerebral spinal fluid. Then you see the MRI, and that's probably the biggest thing, those bright spots of demyelinization. Remember with MS, that's what's happened, is the myelin is destroyed. Your body is destroying myelin. And it's an autoimmune, it's caused by virus, but that's what happens is it causes your body to start destroying the myelin in the central nervous system. Does anyone know what a nerve conduction velocity test is? Has anyone seen one or heard of it? They do it with an EMG. It's actually a common thing that PTs do in certain states where they test a certain nerve. A real common one that they do for the lower extremity is they'll go in behind the popliteal space and do which nerve do you think? That one right down the back of the leg. If y'all don't know the nerve that's going down the back of the leg, then we're in trouble. From the knee down, which one goes right down the back? It's the tibia. Remember the tibia goes down and does the gastroc, and did I say that right? Y'all all look like you have no idea. This is not good. The tibia nerve does. I need to practice. Go over Jeopardy again. Okay. So it's the tibia nerve, and so they test it, and what they do is they shock it, and then you watch for a movement.
Do they stick needles in?
That would be the EMG. They don't do, with the nerve conduction velocity, it's actually an electrical shock.
I think
it's
they did
painful,
that.
by the way.
I think they did that to my dad.
An EMG. They probably did do an EMG with him, and maybe a nerve conduction. Did they stick needle? Well, this one is electrical stim. Like they stimulate it, it's painful, and you'll watch for
Yeah,
movement.
he said it was really painful.
Yeah, it is painful, yeah. And probably for him, he probably has a little bit of hypersensitivity, so it might even be more painful for him. And then some of the blood studies will have a change in the T or B cells, and that's part of your immune system in the lymphocytes. So those are just some of the things they look at to diagnose it, but mainly it's the sclerotic patches with MRI.
I was curious about that slide about the frequency, and I'm finding online people talking about it's correlated to vitamin D production.
Which is a little scary, because how many of y'all have had the vitamin D deficiency?
Yeah, how many people spend a bunch of time inside? But
Well, we just don't, we're not out in the sun like we used to be as a society. I've had students in my program that have 0 vitamin D in their system.
Yeah.
And they had to go and have even a infusion of vitamin D.
It's,
So y'all make sure you have your vitamin D.
it's
checked.
basically on a latitude x-axis, and so like the real southerly latitudes and the real northerly latitudes, are more common.
More on the
And then-
ends,
And then on
okay.
the equator, it's like less common to have it, because of obviously the
Because
sun.
so they are, I'll have to put that in, so I'll read
it's
that,
interesting.
I'll go back and read that. So vitamin D study, okay,
Yeah,
y'all write that down, there you go. Well, so you wonder about the viral part of it. I don't know. I guess a virus, if you're prone to issues, and you don't have a good vitamin D, that, I do know that vitamin D really affects your immune
it
system.
does.
So if you don't have enough vitamin D, then your immune system is not functioning correctly. And that's fairly new. I mean, it's not new research, but we're finding that Americans have a lot of vitamin D and magnesium deficiencies. And there's no reason for that. That's just kind of weird when you think about it.
All this technology everyone stays inside.
Yeah, that's really true. We don't get out in the sun very much. And we don't let our children out in the sun because we're afraid they're gonna get stolen, aren't we?
Not in Greenwood. Those heathens run around like crazy.
What?
I said not in Greenwood. Those kids are everywhere, just wanting to get hit. Their parents just sit and just don't even care.
That's because they're worried about vitamin D, so they're not,
Yeah,
just throwing them
it's-
out there for you to hit.
I know. I about hit one the other day. I was
Ooh,
like, you
that's
better,
scary.
better get your kids.
I think overall people are not letting their kids out as much because they're afraid to leave them outside by themselves. So anyway, that's my thought on it. How do you mamas feel? Are y'all kind of afraid to let your kids play outside?
I live in a country, they can go there once.
Okay. Well, you know, I think it depends a lot on where you live, you know, and if you, are out kind of away from that. Okay, clinical symptoms. Probably the first thing that shows up normally are sensory changes. They'll start feeling numbness somewhere, and it'll usually come and go. And they usually, probably the thing that makes them go get tested is the fatigue factor. Often out of proportion to the extent of the disease, they're just very fatigued. Then they start having cognitive impairments. But you know what, if you're real fatigued, you don't think straight, do you? You know, it's just the way life is. So judgment or reasoning, emotional liability, what would that be? They lose, you know, they're very emotional. They easily cry. They easily get angry. They easily do things. And then depression, which is part of not feeling good. All of those things kind of are a vicious circle. And then the autonomic dysfunction, a lot of times with MS you do see bladder issues. And then possibly, it is a central nervous system disease, so you're going to see, sometimes I've worked with MS patients who have an exacerbation and they'll present like a stroke. It's real common for that to happen. So they may possibly have spasticity, muscle weakness, balance issues, ataxia. So basically, you just have to evaluate them, or your PT has to evaluate them, and then you work on whatever you need to work on. They'll have an exacerbation, and they'll get where they can't walk, and so they're back in a wheelchair all the time. And so you're going to go in and get them walking again. Medicare will definitely let you do that. Because when someone has what's called an exacerbation, then they get worse, right? And so if they lose function, then they're not able to take care of themselves. So if you get back in there and do therapy with them and get them in and out of bed by themselves again and get them walking again, that's a big deal. So it really is. But you can't really say, I'm going to do all these things with this MS patient, because all of them are different. I have a good friend who has MS, and she has 2 little kids, and she works full-time as a nurse, and she just functions. But hers is not quite so severe, but she definitely has the sclerotic patches. I mean, it's been diagnosed, but she hasn't had an exacerbation in a long time. It's real common for it to be diagnosed, and then people go into remission, sometimes for 20 years before it comes back. So we're going to talk about that right now. Disease course is unpredictable. The majority of cases are RRMS, which is relapsing remitting. So this is where they have periods of exacerbation, they get bad, and then you build them back up and then they go into remission. This is probably the most common. You do kind of see a progressive deterioration, but some of them will go right back up to that level. They'll have another exacerbation, and then hopefully you're going to get them back into remission. You can't do it, but their bodies do it. What do you think affects MS? What affects all of us in our health?
Diet.
Diet. I think diet's a biggie.
Sleep quality?
Right? Pardon?
Sleep quality?
Yeah, sleep quality, if they sleep well. If their stress level makes a big difference. So all those things can certainly bring on disease earlier than it would have been if you have the virus in your system, right? So you have periods of exacerbation and remission with the RRMS, relapsing remitting. The primary progressive MS is not good. It's rare. This is the girl that died in 6 months. They have a relentless progression without any relapses, so they just get worse and worse and worse and worse. They never recover anything when they go. They don't ever go into a remission. So that's primary progressive MS. That's 10%. Secondary progressive MS, it begins with relapses and remissions, but then becomes progression, and then just gets where it's really bad. So these are the two really bad cases, where it's a primary progression and then a secondary progression. Because it just gets where they're progressing and getting weaker and weaker and weaker. But it does start out with the relapses and remissions, where they have exacerbations and remissions. And then the progressive relapsing is progressive from the onset, but has clear acute exacerbations with and without full recovery. And I don't know exactly, it is progressive, but I think there's no question on these when they have an acute exacerbation and they get really bad. Like they go from walk-in to going to bed, that kind of thing. I think it's what that's talking about, where that's different. But the majority of them, kind of you think of as periods of exacerbation and remissions. That's what I would say about my friend. That's what she's in. Right now, she's been probably in remission for at least a year. I haven't heard anything, where she's had any issues for that long. With Aaron's patient, we don't know how he started. He may be a secondary progressive, but he's obviously where he's gone downhill pretty quick. So he's either a primary progressive or a secondary progressive, I think. Okay? But y'all really don't know any MS patients? Any friends or anything? I think that's wonderful. And again, it's not as common here, right, as in other places. When I lived in New Mexico in Roswell, we had a lot of cases because people moved to New Mexico out of the northern parts because, and they would move there from real humid areas. We're going to find as we get into treatment that MS patients do not do well in heat at all. And so living here would be hard on them. And the thing about New Mexico is even though it gets hot there, it's a dry heat. And if y'all aren't familiar with dry heat, it's so different. The wind can be blowing and it be 100 degrees and it's not even hot. It's just really different. Where here it can be like it's been 72 degrees and so humid that it's actually been hot at 72 degrees. Have y'all felt that? I don't know. I mean, that's the way it was where I was in Ada. It was just hot the whole time I was there, and I thought I get up in the morning, it'd be 66 degrees, and it would be, this is hot. So, anyway. Okay, so some of the medical management, here's just some of the immune system medications. Avonix, Copazone, there's just some different things that sometimes they work and sometimes they don't. They try different things with them. I do know a lot of MS patients who've tried a lot of the medicines and they've gone off of it. They're not doing any medication. They mainly try and take care of their issues with correct diet and exercise and things like that. But they may not have the real severe case, right? They just have that relapsing and recurring. Minimize progression is what we do. We try to help them to be aware maybe of what's caused the progression. Do we do patient education in the area of stress? Is that an area that we can function? Yeah, you will, because you're gonna spend more time with them, right? So sometimes when people go into a relapse, they just went through a divorce. They just lost a parent. They were in a car wreck. So, just to kind of make them aware that that's what's caused this. People don't self-evaluate very well. Do y'all feel like y'all are good self-evaluators? What's happening in your life and how that's affecting you? Because right now, I'm hoping school is the most, the thing that's affecting you the most, because you're fixing to get out of it, right? But eventually. But it's pretty, y'all are dealing with stress at school, but I'm sure many of you have other stresses that you deal with because y'all have families. But just all those different things to be able to help someone through that. That doesn't mean that we're going to counsel them. What do? Maybe we send them for counseling or recommend they go talk to somebody. Maintain an optimum level of functional independence. So our goal is to make them functional again. So that can, in a rehab setting, what are we looking at? What are the 3 things we look at the most? Gait, bed mobility, transfers, just like on that, the questions that Jayla had you look at it the way, those are the 3 things we look at, that's what we do. So those are the 3 things that you're gonna really want to get them working. And also some other functional independence is, can they go back and stand long enough to cook a meal, right? That's more of an OT area, but if you get in there in home health and OT's not in there, you might do some of that. You're gonna look at standing tolerance, and can they reach up into the cabinet and not lose their balance? Prevent or decrease secondary complications. Some of this actually goes into even bed sores. If they're in the bed and you're dealing with them, they can be all different levels. Maintain respiratory function is a big one, because they do lose their respiratory, and end up sometimes it just affects them that way because those muscles are affected also. So what would y'all do to maintain respiratory function with an MS patient? Y'all all have this skill now. What would you do with them?
First lip breathing.
You would learn pursed lip breathing, diaphragmatic breathing, so you teach them those skills that y'all have. You look at their posture, right? Are they slumped down when they're sitting in their chair? All of those different things. Some of the things that we do is energy conservation, how to manage fatigue. You will find that most of them has a downtime during the day, and you might write this down if I don't have this in this PowerPoint, but there's always kind of a downtime for MS patients. The majority of them will be right after lunch, and they need to go take a nap. It's just a common thing with them. Some of them, though, it'll be at 10 o'clock in the morning, or it'll be at 9 o'clock in the morning, and so you need to educate them on that. Almost all of them have a downtime like that. And so the main thing that you don't want to do is do their therapy during that time, right? Because that would be bad, so they need to rest during that time. And then a lot of patient education. People you think that they would know and be educated a little bit in areas of different diseases, but they're not. And exercise does have to be performed in a cool environment. They do not do well in a heated pool at all. You never put an MS patient in a heated pool. What is the pool temperature of a heated pool? Anybody that...
Is it?
Did they tell you, Dakari?
I can't remember.
Okay, a heated pool is 92 degrees. And it's like getting into a really warm bath. It really is. The majority of, so you want a cool pool. If someone is competing in a pool, normally they keep it around 76 degrees, 76 to 80 degrees, 76 to 78. Did any of y'all compete ever in pool and swimming? And so that's just to give you an understanding of where you're at. So a lot of these pools that cater sometimes to the older population, like if you go over to Baptist and go into their pool, they keep them around 79 to 80 degrees. What do they keep it at?
Oh, no, I'm scratching my.
Oh. Anyway, they keep it a little warmer than what would be ideal for a swim team. Unless the swim team's competing there, which they used to. I don't know if they do anymore from one of the schools up there. But just to give you an idea, so normally a therapeutic pool is 92 degrees, so you would never put a MS patient in that. The other thing is you want to exercise them in a cool environment, so you want to have an air conditioner. And so if you're in a home health setting and they don't have an air conditioner, you're going to, hopefully in this part of the country you would, wouldn't you? Okay, so any questions about MS?
What would you do to help them, really?
What would I do to help them?
Yeah.
I mainly would look at, I would be careful about not overworking them, but I would start doing strengthening. I would start doing gait training. You would look at where they're limited. Your PT is going to do that, and then you'll just start them trying to get in and out of bed by themselves. You kind of look at what they've lost.
Right.
Being able to transfer. So you want to make sure their caregiver can take care of them at home. So you kind of look at the level that they're at, and then you just come up with a program for them. There'll be strengthening. You would deal if they have pain. Sometimes they'll have pain in their joints, and you have to deal with that kind of like an arthritic patient. So all of those things. Does that help?
Yeah.
Just kind of where you'd start. They're kind of a typical rehab patient, and so you'd look at what they're able to do, and your goal is to get them where they're as independent as possible.
Right.
My goal has always been that my patients stay on their feet and walk as long as they can. That's always been that people are on their feet the day they die. That's what I like, is for everybody to be surprised when they die and they're all on their feet the day they die, because that means they're functioning independently, right? So that's why I pray for patients, is that they're on their feet till the day they die. Because that's really, life is much more manageable and enjoyable for them as they get older. Okay. Parkinson's disease. How many of y'all dealt with Parkinson patients? Okay. And did any of you do the big program? Or some of you? Were there some big therapists trained? There's a one, huh?
They had them at Total Rehab, but I wasn't around to see them go through the whole protocol. Apparently it takes like 5 days a week.
Yeah, it's a 5-day-a-week program, but Medicare's paying for it because it's so effective. They've done some great research on it. And you have to have someone very motivated. But it's really a wonderful new process, but you have to be trained in it, and you have to be certified before you're allowed to use it. They're very, basically and you have to be recertified like every 2 years, I think. But it's well worth it if you end up working with Parkinson's. I've wanted to do it myself, but I just haven't. But what it is you take a Parkinson patient, and all of your therapy are big movements. It started out mainly with speech, and so they would have them yell things, and really open their mouth wide. And so it started out as a speech treatment for Parkinson's, because do you know that Parkinson's patients get where they lose their ability to push air out, and so they get where they almost whisper to you, and they don't open their mouths as they get severe. But anyway, big is a great thing with Parkinson's. They've had good luck with it. And we know what the etiology is, because we just do. It's a dopamine deficiency, and it has to be a depletion of 70 to 80%, which I think is a lot. And remember that it's produced and stored in the substantia nigra, in the midbrain and the basal ganglia. It is a progressive neurological condition that affects the motor system. And the 4 main symptoms that you see are rigidity. So they're very, they don't have any, they're just real rigid movements. Bradykinesis, what is that?
Slow movement.
Slow movement. And then a tremor. And so this is where you have the resting tremor. You might put out to the side there, pill rolling is a common thing, and this is pill rolling, where their fingers do this kind of movement. And then postural instability. So lesions in the basal ganglia change the character of movement rather than produce weakness or paralysis. So basically, what you're looking at is you don't have enough dopamine, and so it affects your muscles, and not necessarily, the effectiveness of the movement, the character of the movement versus getting weak. But they do get weak because they quit moving, but they don't get paralyzed, I guess is what we're saying there.
How do they test how much dopamine you've lost?
How do they what?
How do they test how much dopamine you've lost?
I have no idea. I'm assuming that they can, I don't know. Look that up. Maybe it's, I don't know if it would be in your blood system, in your bloodstream.
When you say postural instability, do you mean like they can't stand up? Like they'll
No,
fall
they
over?
mainly, well, yes, and they lose their balance ability, but they also get this real forward shoulders and kind of close down. You have to really, and because of that, an instability means they fall forward, and so yeah, it's more of a balance issue. Takes their balance. Okay, so we have a number of people who are famous. You'd think they'd spend a little more time on Parkinson's because of it, but Muhammad Ali he's dead now, isn't he? Has he died? Yeah, I think so. Anyway, he had it really bad, and we know what his cause was, right? Don't y'all? He was a boxer. Do y'all know who Muhammad Ali is?
Yeah.
Okay. I was looking at some of these names and I thought, y'all aren't even gonna know who these people are. Y'all know who Neil Diamond is?
Singer?
He's a singer. Many years ago. Robin Williams, y'all know who Robin Williams is. He had been diagnosed with Parkinson's right before of course he committed suicide, I believe, but that may have been a part of it. He had Parkinson's for a while. President Bush, first President Bush had it, remember, before he died. And he really got where he could not, he went everywhere in a wheelchair. He couldn't walk. But probably Michael J. Fox has brought more attention to it than anybody else. I remember when it happened to him, and it was kind of weird. He and another young man got it at the same time, and they were doing a movie in Canada. So they don't, you wonder what environmental thing brought that on. Because I don't know if they were just more prone to it anyway and it came on early, but what caused that? So that was just kind of what happened with him, but he's gotten pretty severe. He has a lot of movement in his arm, and he's had all the brain surgery, he's had everything type of thing. But if you'll watch him on TV, he normally will stick his hand in his pocket, because this hand has a tremor in it at rest, it just goes crazy.